Welcome to the deep dive. Today, we're getting into something really fundamental for potentially hundreds of thousands of people, vascular access for hemodialysis.
It really is a lifeline.
Absolutely. And if you, or maybe someone you care for, is dealing with kidney disease, perhaps looking at dialysis, or even if you're just curious about this area of medicine, you know how vital getting this right is.
hmm Critically important.
We've been looking at some, well, quite significant source material for the clinical practice guidelines from the European Society for Vascular Surgery. Very comprehensive.
Yeah, they're dense. Written by specialists, really.
Exactly. But our goal today, our mission, is to sort of cut through that medical jargon. We want to pull out the really practical, need-to-know information, especially for you, the patient, the caregiver, anyone wanting to genuinely understand this crucial topic.
It's like navigating a dense forest, like you said.
Yeah, and we're trying to clear a path, make it feel less overwhelming, more accessible.
Okay, so right at the center of it all is vascular access itself. What is it? Well, simply put, it's creating that essential gateway. It's the connection needed so a patient's blood can flow out efficiently to the dialysis machine.
Get clean.
Get cleaned, yeah, and then be returned safely to the body. For someone whose kidneys have failed end-stage renal disease, as it's called, this isn't just helpful. It's absolutely vital for hemodialysis treatment.
And more people are needing this treatment.
We are seeing that, yeah, globally. Factors like rising rates of type 2 diabetes, high blood pressure, they contribute heavily to kidney failure. Plus, people are living longer with other conditions, so we're seeing, larger proportion of older adults needing dialysis too. That brings its own set of challenges for access.
Right. So what are the main ways to create this access? What do the guidelines focus on?
They really focus on three main types. First, and this is generally the preferred option, is the arteriovenous fistula, often just called an AVF. Imagine surgically connecting one of your own arteries directly to a nearby vein, usually in your arm. This connection makes more blood flow into the vein, causing it to get bigger and stronger over time. Maturation, they call it.
Using your own tissue.
Exactly, your own vessel. Then the second option is the arteriovenous graft, or AVG. If creating that natural fistula isn't feasible, maybe the veins aren't suitable. Doctors can use a piece of synthetic tubing.
Like a small pipe.
Sort of, yeah. A tiny flexible tube to get an artery in a vein. It creates a similar pathway for the blood, but through this graft material.
Got it. And the third?
And the third is the central venous catheter, or CVC. These are flexible tubes inserted into one of the large, deep veins, often in the neck or chest. Part of the tube stays outside the body, ready to be connected to the dialysis machine.
Okay, so fistula using your own veins, graft using a tube or a catheter directly into a large vein. Let's talk more about that first one, the fistula, the AVF. You said it's preferred.
Yes, strongly preferred where possible. The guidelines really emphasize this, using native vessels first. You might have heard of things like the Fistula First initiative in the U.S.
I have, yeah. Why such a strong push for fistulas?
Well, the evidence points to several key advantages. The guidelines highlight that fistulas generally have better long-term outcomes. They last longer. Crucially, they have a much lower risk of infection compared to catheters.
That seems huge.
It is. And some studies even suggest patients with a well-functioning fistula might have a lower mortality risk compared to those relying on long-term catheters. It's your body's own system. Just adapt it.
But it's not always a guarantee that a fistula will work perfectly.
No, it's not. Several things can affect its success. Patient factors, for instance. Age and diabetes can sometimes slow down that maturation process, the vein strengthening, or increase the risk it might fail. The guidelines also mention women might sometimes need more procedures or even end up needing a graft if the fistula doesn't mature properly.
And the vessels themselves matter too, I assume.
Absolutely. The quality and size of the artery and vein are critical. The guidelines actually recommend minimum diameters they look for before surgery, using ultrasound to give it the best shot. Location is also key. Usually the non-dominant arm is chosen, if possible, to preserve function in the dominant hand.
What about using the leg?
That's really considered a last resort, only if upper limb options are completely exhausted. Leg access carries higher risks of infection and potential problems with blood flow to the foot, what's called ischemia.
Okay. And where are fistulas usually placed in the arm?
Common spots are the wrist, the forearm, or the upper arm. Upper arm fistulas can provide really high blood flow, which is good for dialysis efficiency, but they do carry a slightly increased risk of stealing too much blood from the hand, or rarely causing strain on the heart because of the high flow.
So there are trade-offs.
There are. And what's really vital for listeners to grasp here is that while these guidelines give strong recommendations, you'll see things like Class 1 recommendation, meaning strong evidence supports it. They aren't rigid rules.
Right.
They're a guide. Every single patient is unique. Doctors need that flexibility to tailor the approach. The fact that surgeons, nephrologists, radiologists, and nurses were all involved in writing these guidelines, that tells you they aimed for practicality in real-world care.
That multidisciplinary approach makes a lot of sense. Okay, so if a fistula isn't the right fit, or maybe one failed, what's the next step? You mentioned grafts, AVGs.
Exactly. The arteriovenous graft is often the next option considered.
Using that synthetic tube.
Right. The sources suggest grafts can work well, provide good dialysis access, especially in the shorter term. However, the guidelines are quite clear that maintaining long-term function with a graft can be, well, challenging.
That's so.
They're more prone to blockages,
Yeah.
narrowing, called stenosis, or clotting, thrombosis. Patients with grafts often need multiple interventions procedures, like balloon angioplasty to stretch the narrowed part, or sometimes surgery just to keep that graft open and usable. The guidelines mention patency rates, like maybe only 40–50% staying open for a year without needing a fix first.
So more upkeep required, potentially.
Often, yes. Now, moving to the third option, central venous catheters, CVCs. The guidelines definitely acknowledge their role. They're often used temporarily.
Like in an emergency.
Exactly. If someone needs dialysis urgently and doesn't have a mature fistula or graft ready, or they're used as a bridge while a new fistula or graft is healing and maturing.
But not ideal for the long haul.
This is where the guidelines send a very, very clear message. For patients and caregivers, this is crucial. Using CVCs as a long-term solution carries significantly higher risks.
Higher risks of what specifically?
We're talking serious infections, bloodstream infections, more complications overall like clotting or damage to the central veins. And unfortunately, studies consistently show a higher risk of mortality compared to patients using a fistula or even a graft.
Wow. So really avoid them if possible for permanent access.
That's the strong recommendation. Class 1 evidence against routine long-term use. They're generally only considered for permanent access if all other options are truly impossible. Perhaps someone has severe blood flow issues in their arms, making surgery too risky, or sadly, in patients with a very limited life expectancy where the time and surgery involved for a fistula or graft might not be appropriate.
I see.
And the guidelines specifically warn about catheters placed in certain veins, like near the collarbone, subclavian, or in the groin, femoral. These carry particularly high risks of infection and can cause long-term damage and narrowing of those vital central veins.
Okay, that's a really important distinction between temporary bridge and long-term plan.
Yeah, sure.
Let's switch gears a bit. What about preparing for access creation and the care right afterwards? Sounds like there's practical advice there too.
Absolutely. This section is packed with things patients and caregivers can actively participate in. Before surgery, the number one thing is venous preservation.
Protecting those veins.
Yes. This is a key takeaway you can act on now, even if dialysis isn't immediately needed. The guidelines strongly advise avoiding IV drips and blood draws in the main veins of the arm likely to be used for future access. We're talking the cephalic vein on the thumb side, the basilic vein on the pinky side, the veins in the elbow crease.
So tell the nurse or doctor if possible.
Definitely. If an IV or blood draw on the arm is absolutely necessary, the back of the hand is generally a much better choice. Why? It saves those larger, more crucial arm veins, keeping them healthy and undamaged for a potential future fistula. Think of it like preserving the best building materials.
That's a great analogy. What else happens before surgery?
Your doctor will do a physical exam, checking pulses and looking at the veins. And often they'll use duplex ultrasound, that sound wave imaging, to map out your vessels, check their size and suitability, and plan the best type and location for your access.
Okay, surgery happens. What then? What should you expect right after?
The evaluation needs to happen soon after. And this is where you, the patient or caregiver, play a vital role. You need to learn to check for the thrill.
The vibration.
Exactly.
Okay.
It's a buzzing or vibration you should feel if you gently place your fingers over the access site. Some describe it like a purring cat. You can also listen for the bruit, a whooshing sound of blood flow, sometimes audible even without a stethoscope.
And feeling or hearing that is good.
It's essential. It confirms blood is flowing correctly through your new fistula or graft. Not feeling the thrill or hearing the bruit is a red flag. It needs to be reported to your medical team immediately, urgently.
Got it. Thrill and bruit mean it's working. What else post-op?
Wound care instructions, of course. And crucially, avoiding any compression on that arm. No tight sleeves, No carrying heavy things on that side, and absolutely no blood pressure measurements on the access arm ever again.
That's a permanent rule.
Permanent rule. Your team should also teach you warning signs. Redness, swelling, discharge signs of infection, any bleeding from the site, or symptoms like your hand feeling unusually cold, numb, or painful that could indicate ischemia. Not enough blood flow getting past the access to your hand.
And what about exercises?
Yes, gentle hand and arm exercises, like squeezing a ball, are often recommended after surgery. Studies suggest this can help encourage fistula maturation, especially for those lower down in the forearm or wrist.
Makes sense, encouraging flow.
And that's self-monitoring of the thrill or bruit. It's not just a one-time check. You should learn how to check it regularly, maybe daily, and report any changes if it feels weaker, disappears, or changes character right away.
So, constant vigilance. What about using the access? How long does that take?
Right. Fistulas need time to mature. That vein has to enlarge and thicken enough to handle repeated needle insertions for dialysis. Typically, this takes about 4 to 6 weeks, sometimes longer, sometimes a bit shorter under close watch. Grafts, because they're synthetic, can often be used sooner, maybe 2 to 4 weeks, sometimes even earlier.
And if it doesn't mature?
If a fistula isn't ready for use by about 6 weeks, the guidelines say it needs investigation, and ultrasound or other tests to figure out why it's not developing properly.
Okay, incredibly useful practical stuff there. Protecting veins beforehand, checking the thrill afterwards, knowing the warning signs. It really emphasizes your role in your own care.
Definitely.
Now, let's move to the dialysis session itself. The cannulation, inserting the needles, this seems like a critical point of contact.
It absolutely is. And the dialysis nurses are the experts here. They see your access multiple times a week, they perform this delicate procedure, and they're really on the front lines monitoring its health day to day.
What do the guidelines stress about cannulation?
Meticulous skin preparation is paramount before every single cannulation. The sources note that dialysis patients can be more likely to carry bacteria like Staph aureus on their skin.
Right.
So introducing that into the bloodstream via the needle is a major infection risk. Thorough cleaning of the skin with an approved antiseptic, using clean gloves, it's non-negotiable. A vital step every single time.
Makes sense. What else happens before the needles go in?
Before cannulation, the guidelines recommend the nurse does a quick physical exam of the access at the start of every session. Looking at it, inspection for redness, swelling, any bulges or aneurysms. Feeling it, palpation for that thrill, checking for tenderness, and listening to it, auscultation for the bruit.
Every single time.
Every single time. It's the primary way to catch subtle changes or early signs of dysfunction before they become big problems. Needle choice, the gauge, and the angle of insertion are also important, matched to your specific access and flow needs.
And how are the needles actually inserted? Are there different methods?
Yes, the guidelines discuss techniques. The most commonly recommended method is the rope ladder technique.
Rope ladder.
Think of climbing a ladder. The nurse rotates the puncture sites along the usable length of the fistula or graft, different spots each time, moving up or down the ladder. This prevents repeatedly traumatizing the same small area, which helps preserve the vessel wall over the long term.
Spreads out the wear and tear.
Exactly. Then there's the buttonhole technique. This is quite different. After an initial track is established by a skilled cannulator, the exact same sites are used every single time, often with blunt needles that follow the preformed tunnel.
Okay. Any advantages or disadvantages to that?
The guidelines mention potential pros. It might be easier for self-cannulation. Some believe it might reduce aneurysm formation. However, and this is a big hitter, however, it's associated with a reported increased risk of infection.
Infection again?
Yes. Often linked to challenges with really thoroughly cleaning the site and managing the scab that forms over the buttonhole track. It requires meticulous technique and hygiene. It's also not used for grafts, only fistulas. So while it's an option, that infection risk is a major consideration.
Good to know.
The guidelines also note that the experience of the staff doing the cannulation does correlate with better access outcomes. Experience matters.
Understandable. What about after dialysis when the needles come out?
Proper technique is important then too. Apply gentle, direct pressure only over the needle exit sites, usually with 2 fingers. The key is not to wrap anything tightly around the entire arm, like a tourniquet, as that can reduce blood flow to the access itself.
Just pressure on the spot.
Just on the spot. And if it bleeds for an unusually long time despite pressure, that could actually be a sign of an underlying issue, like a narrowing further down the vein causing back pressure. Needs looking into.
So even how you stop the bleeding gives clues.
Okay.
Building on those daily checks, what about more formal monitoring? You mentioned surveillance.
Right. So monitoring is that physical exam the staff do each session. Surveillance means using specific tests, usually periodically, to check function, even if things seem okay on exam.
What's the goal?
Early detection. Finding problems like stenosis that narrowing ideally before it leads to a clot. Thrombosis. Catching it early allows for intervention to fix the narrowing, keep the access working well, ensure you get effective dialysis, and hopefully prolong the life of the access.
And how is this done?
The guidelines reiterate that the routine physical exam by trained staff at every session is still the cornerstone of monitoring. That's Class 1 recommendation.
Okay.
If that exam raises suspicion, maybe the thrill or bruit changes, maybe dialysis pressures are consistently high, or there's swelling, then duplex ultrasound is the recommended first-line test.
The sound wave picture.
Exactly. It lets them see the blood flow directly. Other tests like angiography exist, but ultrasound is usually the first step if a problem is suspected.
Can they measure flow rates or pressures?
Yes, things like blood flow volume through the access or pressures measured during dialysis can indicate a potential narrowing. But the guidelines caution against relying only on these numbers to decide on treatment. They need to be interpreted alongside the physical exam findings. A low flow number plus a change in the thrill. That's concerning. A low number with a perfectly normal exam might just be watched.
Context matter.
Context is everything. Even things like how well the dialysis is cleaning your blood measures like KTV or URR, if those unexpectedly drop, it could be a subtle sign of access dysfunction, often a narrowing, slowing things down.
Okay, so constant watching, checking, and sometimes specific tests. But what if problems do develop later on? What are some common late complications people should be aware of?
Good question. These can happen months or years after the access is created and working. Aneurysms are one. Those localized bulges or balloons in the vessel wall.
Right.
Key point from the guidelines. Do not cannulate into an aneurysm. Depending on size, growth rate, or if they cause issues like pain or limit cannulation sites, they might need surgical repair. Often, an underlying stenosis, a narrowing downstream, is causing the bulge, so that needs checking too.
Makes sense. What else?
Infection. Always a risk, but especially high with catheters and, to a lesser extent, grafts. Look for local signs: redness, swelling, warmth, pain, discharge around the access. But sometimes a fever might be the only sign.
So unexplained fever needs checking.
Absolutely. Access infection needs prompt diagnosis and antibiotic treatment. Severe infections, particularly involving grafts material, might require surgical removal of the infected graft segment or the entire graft.
Serious stuff.
Very. Then there's stenosis and thrombosis. We've mentioned these. Stenosis, the narrowing, is common, often in the vein draining the access. If it's significant enough to cause problems, altered throat bruit, high pressures, swelling, poor dialysis, it needs fixing, usually with balloon angioplasty, maybe a stent.
And thrombosis.
Thrombosis, the clot, often happens because of an untreated severe stenosis. If your access clots the thrill and bruit suddenly disappear, it's an emergency. You need urgent treatment, usually a procedure to remove the clot and fix the underlying narrowing to have any chance of saving the access. Time is critical.
Okay, urgent action needed there. Any other major ones?
Ischemia, where the access steals too much blood flow from the hand or arm. Symptoms can range from the hand feeling cold or numb to pain, especially during dialysis or exertion, non-healing finger ulcers, or in severe cases, tissue death.
Who's most at risk?
It's more common with certain access types, like those high-flow upper arm fistulas, and in patients with existing circulation problems, like diabetics or the elderly. Severe acute forms, especially one called ischemic monomelic neuropathy affecting the nerves, are surgical emergencies. The guidelines state the access must be tied off immediately to prevent permanent nerve damage. Less severe ischemia might be managed by fixing a narrowing or reducing the access flow surgically.
Wow, that sounds scary. Immediate action needed.
It highlights the potential downsides, yes. There are also issues like blockages higher up in the central veins towards the heart, often caused by previous catheters. These can cause significant arm swelling and are notoriously difficult to treat long-term.
So a whole range of potential issues down the line.
Indeed. And for some patients, particularly those on dialysis for many, many years or with very complex medical histories, they might unfortunately exhaust the standard options in both arms.
What happens then?
That leads to what's termed complex or tertiary access. These are challenging situations requiring highly specialized surgical skills, using less common vessels, maybe creating bypasses with grafts in unusual locations like the chest wall or thigh. Even complex catheter placements, like through the back into the vena cava, exist as last resorts. Of course, peritoneal dialysis might also be an option for some. These are definitely higher risk procedures.
It sounds like a real challenge for some individuals. It also sounds like, despite all this knowledge, there's still things we don't fully understand. Did the guidelines mention that?
They did, quite openly.
Huh.
The document includes a section specifically on gaps in the evidence.
Oh, interesting.
They acknowledge that many recommendations, even important ones, are based more on expert consensus or lower-level studies, simply because large-scale, high-quality randomized trials are lacking in many specific areas of vascular access.
So more research is needed.
Definitely. They list quite a few areas. For example, really nailing down the long-term durability and outcomes of different graft types versus catheters. Comparing fistulas versus catheters specifically in the elderly population, they actually mentioned a trial is underway for that.
That sounds important.
It is. Also, things like setting up registries to better understand rare but devastating complications, like that ischemic neuropathy. Refining how we use patient-specific factors to choose the best access type for that individual. Studying the actual long-term effects of different cannulation techniques on the vessel wall. Developing better treatments for those difficult central vein blockages. Improving early referral practices so access is planned before dialysis starts. And looking into cost-effectiveness and new technologies, like tissue-engineered grafts.
So lots still to learn and improve upon.
Absolutely. The field is far from static.
Okay, well, we have certainly covered a vast amount of territory in this deep dive. From the basics of what vascular access is, the fistula, the graft, the catheter, and why that fistula is often the top choice. We've walked through the critical steps before surgery, like vein preservation and the essential care and checks right after, like feeling for that thrill. We talked about the importance of careful cannulation during dialysis, the different techniques and the ongoing monitoring needed to catch problems early.
Yeah.
And we touched on those potential late complications, the warning signs to watch for.
We have a lot to take in.
For you listening, particularly if you're a patient or a caregiver, let's just recap some really key practical takeaways. Remember, protecting your arm veins before you might need access is huge. Avoid those IVs and blood draws if you can. Learning to feel that thrill in your access daily is your personal monitoring tool. Use it. Report any changes, weaker thrill, swelling, redness, pain, prolonged bleeding to your dialysis team right away. Don't wait. Understand that how the needles go in matters. And please, ask questions. Be involved. You are the most important member of your access care team.
Couldn't agree more.
An informed patient and engaged caregiver that's truly central to keeping this vital lifeline working well for as long as possible.
And perhaps a final thought to leave you with, really stemming from that gaps in evidence section we discussed. Even with incredibly detailed guidelines like these, which represent a huge amount of collective expertise, the journey isn't over.
Right.
The fact that there are still so many unanswered questions, so many areas needing more research, highlights that this field is constantly evolving. The push for better evidence, for new techniques, for improved education, for patients, caregivers, and staff alike, it all points towards a continuous effort to improve outcomes and, ultimately, the quality of life for everyone relying on dialysis. It's a dynamic process.
A field still moving forward. That's a great note to end on. That's all for this deep dive. We really hope this exploration has helped make this complex but absolutely critical topic feel a bit clearer and more manageable for you.